Good morning. Today we have two short cases presentation. We will see that if time permits, we'll go to the second case. Presentation will be done by Dr. Mehul Patel, who is a second year junior resident at MR Bangalore Hospital. And our teacher today will be Professor Utpal De, who is Professor of Surgery at NRS Medical College. So Mehul will present the first case of cervical lymphadenopathy. And then if the time permits, we'll pass on to the next case of varicocele. So Mehul will share your screen and present.
Good morning, respected teachers and my dear colleagues. The topic of my presentation is a case of cervical lymphadenitis. Mrs. P, 28 years old student, a resident of Tollygunj, presented with the chief complaints of fever for the past 3 months and swelling in the left side of the neck for the last 2 months. History of presentation. She was apparently well 3 months ago. After which she developed a fever, which was in intermittent in nature, low grade. It usually comes in the evening, associated with excessive sweating in the night. There were no history of chills and rigor and not associated with any joint pain or rash. Swelling in the left side of the neck for the last 2 months. It was insidious in onset, initially smaller in size, approximately 1 into 1 centimeter in size, when the patient noticed it by herself. Gradually the size increased to around 2 centimeter to 3 centimeter over the period of last 2 months. Not associated with any pain, no other swelling in any other parts of the body. Patient had a history of intermittent associated with weight loss. For the above complaint, she was evaluated. CB-NAT was done of specimen of sputum. It came out to be positive. So patient was diagnosed as a case of pulmonary TB and was started on anti-tubercular drugs from July 2023. She completed the ATD treatment in January of 2024. There is no history of diabetes mellitus, hypertension, or thyroid disorder, or any other illness. Both parents are alive and healthy, and her grandfather had a history of TB. She is married, has one child. Both child and spouse are healthy. Bladder, bowel, sleeps are normal. Appetite is normal. Mixed Indian, non-vegetarian diet. No addiction present, and belongs to an average socioeconomic class. Menstrual history, normal cycle, a regular cycle, duration 3 to 5 days. Last menstrual period, 1st of January 2024. Physical examination and a general survey were essentially normal. Local examination on inspection, a 2 into 3 centimeter swelling in the left side of the neck, supraclavicular region, level 5. Ovoid in shape, smooth surface, well-defined margin, normal skin over the swelling, and no other swellings. No other visible scars or sinuses present. On palpation, the temperature was normal. There was no tenderness. The swelling was ovoid in shape, smooth surface, margins were regular, firm in consistency, freely mobile, and not fixed to the underlying structures. Skin was normal over the swelling. There were no palpable pulsations. Thyroid in the midline and trachea in the midline, and thyroid glands are not palpable. Examination of the drainage sites: scalp, head, oral cavity, tongue, buccal mucosa, Walden's ring, nasopharynx, tonsils, nasal cavity, paranasal sinuses, thyroid, and other lymph nodes were all normal. Systemic examination was essentially normal. Case summary: a 28-year-old female presented with the chief complaints of swelling in the left side of the neck for the past 2 months. Initially, she noticed the swelling in the left supraclavicular region, which was initially small, then reaching to a size of around 2 into 3 centimeter at present. Fever for the past 3 months and loss of appetite. Patient has a history of pulmonary TB in July 23, for which she completed anti-tubercular drug therapy in January 2024. Examination: 2 into 3 centimeter palpable lymph node at the level level 5 region. The lymph node is non-tender, firm in consistency, smooth surface, not fixed to the underlying structure of skin, with normal systemic examination. My provisional diagnosis is it's a case of tubercular cervical lymphadenitis.
See, Mehul, first, from the provisional diagnosis that you have given, this is a case of tubercular cervical lymphadenitis. Okay. So, can you improve on this? Because it's quite obvious from your history that you have said that this was the patient had suffered from pulmonary tuberculosis. The patient underwent treatment. There is a family history also. So, it's quite obvious that it could be from tuberculosis. But then,
Yes.
can you improve on this? This is a case of tubercular cervical lymphadenitis. I do agree with you, but can you improve a little better?
So, I could say, sir, okay, this is a case of cervical lymphadenitis, probably of tubercular origin, and my disease would also be along with that. So,
She has already undergone treatment, isn't it? So
yes, sir.
that means what? That
Yes,
means
sir.
there is either a drug resistant one or it could be a relapse, isn't it? So I feel that in this particular part, if we would have added that thing, that would have made much sense. But then, what did you say about the lymph node? Description of the lymph node?
So it was firm in consistency, smooth with smooth surface, regular margins, and not fixed to the underlying structures.
And it was in the level 5, isn't it?
Yes, sir.
So what are the different levels?
So there are six levels, seven levels, sir. Level 1, which is divided into 1A and 1B, that is submental and submandibular. Level 2, 3, and 4, they are divided on the basis of the internal jugular vein, upper 1/3, middle 1/3, and lower 1/3. And level 5 is in the posterior triangle. Level 6 in the anterior compartment of the neck, which includes the pre and paratracheal, pre and paralaryngeal, and omohyoid nodes. And then level 7, which is mediastinal. So,
Okay, level 7, some people they do not agree with it. They say up to level 6, but yes, you are true that level 7, some of them they also include in the lymph nodes. Okay, now can you tell me the landmarks based on which these levels are usually divided?
yes, sir. Yes, sir. The level 2 lymph nodes are between the mandible and the superior border of the hyoid bone, sir.
Base of the skull, right? Okay, mandible.
Base
Yeah,
of the skull and base of the skull and the superior border of the hyoid
yeah,
bone.
yeah.
Level 3 is hyoid to the inferior border of the cricoid bone,
Arch of the
and from
skull. Yeah.
as of cricoid. And level 4 is from cricoid to the clavicles.
Okay. Now you also mentioned about some draining areas, right? So can you
Yes,
tell
sir.
me what is the importance of knowing about these draining areas and corresponding lymph nodes?
So, like, for submandibular and tongues, the draining areas is the level 1A and 1B lymph nodes. For for oropharynx, nasopharynx, larynx, the draining areas would be level 3. For hypopharynx and from near esophagus would be level 4, and level 5 would also drain the same lymph nodes. Along with that, if any there is an abdominal malignancy or a testicular malignancy, that would also have Varicocele node, that would include in the level 5 lymph nodes.
No. Varicocele is not level 5.
That's correct.
Varicose gland is not level 5. Try to understand. Clarify it. Where is it?
So, Varicocele glands is in so palpable, supraclavicular lymph nodes.
No, it's not exactly supraclavicular. Varicose gland is one of the scalene lymph node, which lies between the two head of sternocleidomastoid. It's not level 5, it's level 4 node.
It actually lies, we consider it as a part of the level 4, right?
Yeah.
Because it lies, as sir said, it lies between the two forks of the sternocleidomastoid muscle. Right. Then why do you say that this is a lymph node? Why is it not a subcutaneous swelling? It could be a subcutaneous, it could be a sternomastoid tumor also. It could be a subcutaneous, any other swelling like a fibroma. It could be a lipoma. It could be something else also. So why do you say it's a lymph node?
So it's along the line of the lymphatics, according to the surface markings. And
Lymphatics are all there in the whole of the neck. You cannot say in the line of lymphatics.
No, okay. If you mention about the line, can you tell me the line of the lymphatics of level 5?
So,
Because of all these lymph nodes in level 5 has got a definite leveling along with it.
uh,
What is the nerve which usually is important in relation to level 5 lymph nodes?
spinal accessory now, sir.
Yeah, so the spinal accessory lymph nodes, that is what we usually say with level 5 lymph nodes. Now, you said it is a lymph node. So why do you say it is a lymph node? Why is it not another swelling? Any other swelling? You have said already, just mention those points.
So because it's formed along the
Firmness does not, actually firmness is a characteristic of a lymph node, right? So you cannot say that only based on firmness you
So
can say
ovoid-
that it is a lymph node. Moreover, a normal lymph node is not firm.
So ovoid shapes swelling not adhered to the skin or any underlying structures, and
Is it
along this
is it superficial to the deep fascia or is it deeper to the deep fascia of the neck?
so deeper to the deep fascia of the neck. Both are actually just some of the
These lymph nodes usually lie in a deeper plane. So the characteristics, the other swellings that are there, apart from a few of them, most of them lie superficial to the deep fascia. This is more in a deeper plane, right? And number two is you said it's the swelling size you have mentioned. You have mentioned about the shape of the swelling, and we have mentioned normal skin over the swelling. So
Yes.
these point, moreover, most of the, if you look at the swellings in the neck of this size, most common differential diagnosis is a lymph node itself. Okay, how many lymph nodes are there more approximately in whole of our body? Roughly 600 to 800, and most of them are concentrated in the cervical region. Okay, what do you mean by, you said the lymph node on inspection, it is ovoid in shape, smooth surface, well-defined margins. Okay, all these you have mentioned.
Yes.
Do you feel that in a patient where you have provisionally diagnosed it at a case of cervical lymphadenitis, you do find this kind of lymph nodes or there is something else typical?
So there is generally for lymphadenitis, there is tenderness in the lymph.
If say cervical pubical origin, is it the correct one?
No, sir.
How are the cervical
lymph nodes? So generally, sir, lymphadenitis in tubercle origin, so lymph nodes are, sir, matted lymph nodes, and the margin is not smooth. It's irregular, and there may be, sir, any discharging sinuses present in them, sir.
Okay, no,
And
no,
also, sir,
wait. So, do you feel that all these things come at the same? Because there are certain, what are the stages of cervical lymphadenitis?
So there are 4 stages.
Tell
First
me
is
the
a stage
fourth
of
one. Tell me the
inflammation.
fourth one. Tell me the fourth one.
Fourth one is a stage of discharging sinus.
No. That is why you don't try to say all these.
For tubercular, sir. For tubercular.
No, initially what happens? Initially there is lymphadenitis. So that means there is inflammation of the lymph nodes itself. Secondly, what happens?
Yes.
Then it spreads beyond the lymph.
Abscess.
Okay, no, then it becomes periadenitis. Means the lymph nodes, there is lymph nodal inflammation. And then the lymph node becomes matted. So initially the lymph nodes are not matted. Once there is periadenitis, then the lymph node becomes matted. Then there is coagulative necrosis, which forms collar-stud abscess. After that, there is cold abscess. And finally, sinus forms. You get my point? So there can be a single lymph node,
Yes.
but then what happens is all those characteristics of a lymph node, they become full blown after this stage. When from the stage of peritendinitis, then it becomes matter. Okay. Now, can you tell me by definition what is lymphadenopathy?
So inflammation of a lymph node.
Lymphadenopathy. It need not be inflammation knowledge. He asks lymphadenopathy.
So swelling of the lymph node due to any disease or disease process.
Increase in number, increase in size, and distortion of shape. So all these constitute lymphadenopathy. Now, is it what kind of lymphadenopathy do you find in tuberculosis? Or in other words, what are the different types of lymphadenopathy? First, tell me that.
Sir, so one which is due to any infective origin, sir.
No.
Localized.
Those are based on the pathology. Those are based on pathology, right? So it could be localized, yes, or it could be generalized.
Oh, yes, sir. Yes, sir.
Huh?
It could be localized. Okay. Yes, sir.
What is generalized lymphadenopathy?
So generalized lymphadenopathy is changes in the shape, size.
No. That is the definition for generalized lymphadenopathy. So what involvement in the lymph node will call this is generalized lymphadenopathy?
So three or more different.
Two or more
different areas of
non-contagious sites.
Non-continuous.
Okay, so that constitutes localized or generalized lymphadenopathy. Okay, right. Now, coming back to your diagnosis of this, okay, tell me a few other causes.
Dr. Day, little about his presentation. I had some observation. Go back. He said the swelling is for 3 months.
Yes.
And in the past history started saying 6 months back patient has pulmonary tuberculosis. Yes. So it's only 3 months gap.
Yes.
So you should not go to the past history. Go back. You see, this past history, July 23. Yes. And 3 months patient is having this. Yes. So it's only gap only 3-4 months. Yes. So better in this patient, history should start with this. On history present illness. Yes. Because it's a 6 months back patient has pulmonary tuberculosis. Down the line, 4 months beyond that patient has. So it should not be a definite past history. It should start with the pulmonary tuberculosis. And then history present illness, go. You have mentioned only about fever and swelling. That's it. But history of present illness is not only elaboration of two chief complaints. This patient is a disease which started in pulmonary tuberculosis and then now present lymph nodes. So patient may have disease in other systems also. So you should inquire about other systemic symptoms, whether patient has got any evidence of tuberculosis in other systems. So you should ask about other systemic symptoms in this. Got my point?
Yes, because history and physical examination are very important in case of
bladder habit, here. Yeah, this. And what do you feel, Dr. Day? If the patient has pulmonary tuberculosis 6 months back and 3 months patient is having lymph node, so it should be a continuous history that patient had how it was diagnosed with pulmonary tuberculosis. Might have been some chest pain, cough, hemoptysis, or whatever, for which he was diagnosed with pulmonary tuberculosis, and then he was on treatment. And after completion of treatment, you see, if he is completing treatment in January, and then he is having this swelling, that means during the treatment, he is having this lymph node being appearing. Yes, sir. So it is in the process of treatment, he is noticing that. So as Dr. They ask you, is it drug resistance? Might be. Because on continuation of the antitubercular therapy, he started having recurrence of fever. He started having the swelling. So it might be a situation that is a drug-resistant tuberculosis.
Can it be something else? Can it be something else?
Yes.
Apart from means drug resistance, what sir said, can it be something else? Like in leprosy, we have we have a anaphylactoid reaction where the lymph nodes after treatment they flare up. So same thing can occur in tuberculosis also, right? So you initiate a treatment and then you find the lymph nodes flaring up and then the response. So that could be, I forgot the name of, there is a symptoms which is related to that. I forgot the name of that, but there is a condition where following the treatment, the lymph nodes flare up and then they again respond. Okay, but one thing is sure, what sir said, see, from your history, what I felt that you are inclined more towards tuberculosis. So that is why I was not asking you much about tuberculosis, because you said, means it appears from your history that you are focused on tuberculosis. Means from your history, everything, it drags you towards tuberculosis. So if you present like this, then what is going to happen is the examiner is not going to ask you anything about tuberculosis. All things they will ask you except tuberculosis. Because you have, means from your history, it's quite apparent. Okay, right. Now, if from examination you have mentioned everything. Now, lymphadenopathy, I mentioned about size. So, what are the benchmarks of those sizes related when you say that it is a pathological lymph node?
So greater than 2 centimeters, sir.
2 centimeters. 2 centimeters is quite large. By average definition, it goes that it is more than 1 centimeter.
Yeah,
right.
Significant.
Except in children and in adults. Which lymph nodes? The submental lymph nodes which you have mentioned. They can be more in size, even normal lymph nodes. In children, up to 2 centimeters, it is considered normal because they are developing their immune system. But for all other areas, it's more than 1 centimeter, excepting one lymph node, that is epitrochlear lymph node, which they say if it is larger than 0.5 centimeter, then it is pathologic. Okay. Okay. Now tell me some other causes of lymphadenopathy, cervical lymphadenopathy.
Patient is on antitubercular treatment. In spite of that, the lymph node is repairing. One situation is drug resistance. Apart from this, what else you can think of that this might be another explanation for this lymph node enlargement?
So along with that, so there is some localized infective origin. He might have tonsillitis. He might have.
So you mean it's a other chronic infection?
Yes.
What else?
So yes. Could be sir lymphoma, sir. Patient might suffer from lymphoma.
No.
Could be metastatic as well. But sir, the features were not consistent with that.
So you see, patient who is on antitubercular treatment and during treatment the lymph nodes are appearing, you have to think apart from drug resistant tuberculosis, you should exclude other possibilities. Yes, you should keep in mind the important differential diagnosis. Okay, so diagnosis could be, one is it could be infective, it could be neoplastic also, right? So infective origin, apart from means lymphomas, what you have mentioned, you should also think about the immunosuppressive diseases which may coexist with tuberculosis or which usually flares tuberculosis, like HIV. In HIV patients can develop means lymph nodes. Okay, right. So now you say that it is a case of cervical lymphadenitis, right? Due to tuberculosis as a cause, means tuberculosis as a cause. How will you proceed with this?
So I would like to do an FNAC of the swelling.
How will you?
Yes, sir.
Would you first go in directly for invasive investigations, or would you like to do some non-invasive investigations first?
So I would like to do USG, sir, to assess the other lymph nodes if they are not. Some might not be palpable.
Okay, so you would like to do an ultrasonography, right?
Yes.
Okay. So what are the things in ultrasonography you would like to see?
So I would like to see the length and breadth of the lymph nodes, sir, because in case of metastatic cell lymph nodes, the breadth is greater than the length, so the shape of the lymph node changes.
Why is breadth greater than length?
So the
Oh,
ovoid shape of the lymph node changes to more
why does the ovoid shape
globular.
change?
Yes, sir.
Why does the ovoid shape change? It could have been length more than breadth also. Tuberculosis and malignancy, both of them, if you look at USG finding, you will find many features which are in common. It's very difficult to differentiate. The thing is that in other cases where there is generalized inflammation of the lymph node itself, there is a swelling as a whole. But in a malignancy, it gets deposited in some places where there is proliferation. So then what happens? Mean vascularity, if you see of a lymph node, it is in the hilar region. Right. So malignant cells, they come and tend to deposit there. And then it starts growing. So what happens is there is increase in the breadth compared to the length. Whereas in an infection, there is generalized inflammation. So the lymph node as a whole enlarges. Right. Okay. Then next.
And so
Ultrasound.
yes, sir. And so the consistency of the lymph nodes, the
What could
You mean the echogenicity, not
echogenicity of the lymph nodes.
Okay. What are the different types of echogenicities you can find?
The hypoechoic and hyperechoic, sir.
Hypoechoic and hyperechoic. Okay. Do you know the meaning of these terminologies? What is hypoechoic? What is hyperechoic? And in whose relation is it said?
So like so tubercular lymph nodes and infective origins lymph nodes, so they are hyperechoic. So there is deposition of
Okay. Means wherever there is increased amount of water, then compared to the tissues surrounding them, they become hypoechoic. Okay. Wherever there is deposition, as you rightly pointed out, there it becomes hyperechoic because the water content becomes less. Once the water content becomes less, there is hyperechocity. When the water content is more, then it becomes hypoechoic. Okay, hypoechoic denotes what?
So metastatic lymph nodes are generally hypoechoic, sir.
Okay. Then what else?
And so
if there is necrosis, yes, or abscess formation, it can be hypoechoic.
So abscess formation also hypoechoic, sir.
Yes, abscess is hypoechoic. Abscess is
liquefaction of the lymph node.
Yeah, so liquefaction means any fluid accumulation can also become hypoechoic. So then means if it is cystic in nature, it will be hypoechoic. Yeah. So, and the others, they will be. Do you know what is a pseudocystic appearance? You mentioned in your provisional diagnosis, but do you know where you find it? You find it in cases of lymphomas, right? So they do not have a cystic appearance, they have a pseudocystic appearance. Okay, what else in ultrasound?
So
see these ultrasonographic features, it's asked. So because it is a differentiation between benign and malignancy. So you should means 1 by 1, 2, 3, 4, 5, 6. So you should go in like that. Means first, breadth greater than length. Then is what you have said, hypoechoic or hyperechoic. Okay. Then what are the highlight changes that you find? Right. Then what about the vascularity? Which part becomes more vascular, which part is less vascular, right? And then lastly, you can say about the pulsatility and resistive index. So these are the points which you should mention in one go, because I have found that this is quite frequently asked in the examination, right? So this is
the outline. The infected nodes are more often smooth, but the neoplastic lymph nodes are more irregular in the outline.
Okay, so you have done an ultrasound, right? What will be your next investigation?
A USG guided FNAC, sir.
Okay, USG guided. From where will you do it?
From the hilar region, sir.
hilar region. No, not of the lymph node. Suppose there is a swelling you find. Which point
Yes.
will you do it? Will you do it from the, means suppose you have placed ultrasound probe, will you go from above? Will you go from below? Will you go directly in?
So I would go from below.
Below. What will be the harm?
Uh, so if there is any discharge post my intervention, sir, so going from below would help it drain it, sir.
So that will result in what? Means I
Sinus.
wanted you to purposefully get into this trap. For all,
Sinus formation. It will
yes,
form sinus.
yes. So
Yes,
you
sir.
never do it from below.
Will
Okay,
go from
going from
yes,
above.
yes,
Same for drainage of
yes.
this thing also. For tuberculosis, remember, in
Abscess.
all abscesses, we usually drain from the dependent part. But tuberculosis, where we always do an anti-gravity drainage to prevent sinus formation.
Sinus formation. Yes.
Okay, right. Now, suppose you have done it, you have done an ultrasound, there is a sinus formation, CBNet facility is not available. Right. You strongly suspect it to be a tuberculosis. What will you do?
So I would do an excisional biopsy and
No. You have done aspiration.
I strongly suggest that it is a
What can you do with this apart from the micro examination?
I would start the patient on according to the sensitivity, sir. I would start the patient on
Why?
since
Why?
it's a sir. Yes, sir.
You have not diagnosed it as tuberculosis. You have done an ultrasound, you have done an FNAC, there is a sinus formation that you find. So what will
So
you
I would like to do a I would like to do a chest X-ray to see if there are signs of pulmonary TB. Then.
Okay, what else? From that local site, can you do anything?
So I could send the sample for CBNet. Sir.
No, I told that CBNet facilities are not available. Now what are you going to do?
Then so acid, so I could send the sample for acid fast stains.
You take a edge biopsy from the edge of the sinus and send it for biopsy. Okay. So sometimes, though it is done in case of tubercular ulcers, but in sinuses also you can do. Right? Okay. Now, so ultimately you say that there is a sinus formation. So it could lead to an ulceration also.
Yes,
okay.
sir.
Now, from clinical examination, can you tell me something which moves your diagnosis more towards tuberculosis than other diseases?
So, matted lymph nodes, sir.
Matted
lymph nodes will.
Yes, 1 second. Sorry. There will be scarring in the adjacent.
Scarring, sir.
Okay. So there will be scarring. Now, so now this is about tuberculosis. So you said something about lymphomas, right? So what, from your history, are there any characteristic features which are suggestive of lymphoma?
So lymph nodes are, sir, rubbery in consistency, sir. And they may or may not be adhered to the deeper structures.
Okay. And do you know what are B symptoms?
Yes, sir. Yes, sir. B symptoms, the patient has a history of night sweats, weight loss, and so
fever.
Fever, sir.
Okay.
Yes.
Do you know the type of name of the fever which occurs in Hodgkin's disease?
Yes, sir. Yes, sir. Epstein fever, sir.
Very good.
There is a pyrexia for 7 to 14 days, and then a pyrexic period of the same duration.
So you do an FNAC from the lymph node. Now, what is the characteristic thing which tells us that yes, this is a Hodgkin's disease? There's a cell, isn't it? Like in tuberculosis.
What if I find on FN? Or if I ask in different way, you have a strong suspicion of lymphoma based on the clinical findings, would you ask for a FNA or you ask for something else?
So I would ask for a excisional biopsy.
Yes. Yes. Why?
So
Why in a suspected lymphoma you should prefer for a excisional biopsy rather than a FNA?
So I would like to know the invasion, if there is invasion of the
Not invasion exactly.
Invasion, not invasion.
What is
breach.
important in lymphoma? Not invasion.
The breach of
No, not breach. If you
You
don't,
see, the lymphoma is a situation where only the cells are not important. You need to typify the lymphoma, number one. Okay, you have to grade the lymphoma. Okay, that cannot be done in FNA. So if you have a strong suspicion of lymphoma, it is better to have a excisional biopsy rather than FNA. What do you find in FNA? Suppose doctor, they ask you, it's a lymphoma. So what is the usual FNA finding in lymphomas?
So there will be increased nucleocytoplasmic ratios and find the cells. Nucleocytoplasmic ratios. More of lymphocytic cells.
We have seen a report of lymphoma. Patient come to OPD. They're all mononuclear cells, lymphocytic cells.
Lymphocytic cells.
Okay, it's not a specific type of diagnosis. So in that case, they always suggest for a excisional biopsy.
lymphoma is actually what happens. There is infiltration of the lymph nodes by lymphocytes. So it is very difficult to diagnose on FNAC, based on FNAC, to diagnose it what type of lymphoma, because you need to do an IHC and then label it what type of lymphoma it is, and then specifically or typically you should give a specific treatment to that. So for that you need to do an excision biopsy, and the most cell which differentiates it from non-Hodgkin's lymphoma is the Reed-Sternberg cell. So that is a big cell which has got two oval-shaped nuclei adjacent to each other. So that is typical of a Hodgkin's disease, right? Okay. So that could be one possibility. So it could be Hodgkin's disease. If I say it is a metastasis from an unknown primary, just briefly tell me the outlines of what you are going to do, because I think that is a separate entity itself, but just briefly tell me what are the things you want to do.
So if it's a metastasis from unknown primary, sir, I would like to do more investigation to search for the.
Tell me
What is the
those.
standard recommended investigation for a metastatic node? One liner. It's investigation. Metastatic node investigation. Described as? No. Before PET scan? It's triple endoscopy.
Triple endoscopy, yes.
So
I'll go for triple endoscopy.
But I'll do a triple endoscopy. Okay, right. So this is so in these three things you need to know about in details when you are presenting a case of cervical lymphedema. Now there is a tuberculous lymphedema. She has completed her anti-tubercular therapy in 2024 January, I think, isn't it?
Yes.
Okay. Now you find that yes, this is a cervical lymph node which is arising from tuberculosis. Now what we are going to do?
So we have to get her tested for sensitivity, RI sensitivity, rifampicin and isoniazid sensitivity, and we can also start the patient on according to the sensitivity. You can start the patient on multi drug resistant TB regimes.
So you need to, means first you need to check about the first line drugs, whether they are sensitive to not. If they are not sensitive to the first line drugs, then we need to initiate the second line therapy.
Yes.
Okay.
What are the few second line drugs?
So like levofloxacin.
One is fluoroquinolone group as a whole.
Fluoroquinolone group, sir.
Apart from that,
okay. So I think Magonda, regarding cervical lymphadenitis, he has answered most of the questions.
yeah. We can then go to the next short case of varicocele. Varicocele. Pre-presentation. Yes.
34-year-old gentleman, shopkeeper by occupation, presents with the chief complaint of swelling in the left side of scrotum for the past 3 years. There's pain in the left side of scrotum for the past 6 months. The patient was apparently well 3 years back when he presented with a swelling in the lower part of the scrotum, which was insidious in onset, slowly increasing in size and grown up to the root of the scrotum. Swelling disappears on lying down and reappears on standing or walking. There is no history of sudden increase in the size of the swelling. There is no pain. The history of pain in the side of the swelling for past 6 months, which is dull aching in type, and it is more towards the evening when the swelling enlarges in size. There is no history of pain abdomen or mass in the abdomen. There are no urinary complaints. The past history is essentially normal. Personal history, family history, and treatment history are also essentially normal. Summary: a 34-year-old gentleman presented with a swelling in the left side of the scrotum for the past 3 years, starting as a swelling in the lower part of the scrotum, which is slowly increasing in size and grown up to the root of the scrotum. The swelling disappears on lying down and reappears on standing and walking, and is associated with dull aching pain for the last 6 months, which is more during the end of the day. No complaints of pain in abdomen or urinary symptoms. General examination is essentially normal. On palpation, there is no local rise of temperature. There is no tenderness. Mass of dilated tortuous veins is palpable on the left side of the scrotum, along the left spermatic cord, extending up to the upper pole of the testis, up to the superficial inguinal ring. Swelling disappears on lying down and with elevation of the scrotum, and reappeared on standing. Cough impulse is negative. Thrill is palpable. Testis is palpable, small on the left side as compared to the right side. Hernial orifices are free and normal. There is no deviation of the penis. Right side of the scrotum and testis is normal, and there is no palpable lymphadenopathy. Digital electrode examination is normal. Systemic examination is normal. On local examination, after taking consent, properly exposed, patient is properly exposed, examined in standing and supine. So,
You have jumbled up.
Yes, jumbled up.
Inspection should have come earlier.
Yes.
Yeah.
Inspection. The left side of the scrotum lies in the lower position compared to the right side. Visible swelling in the left side of the scrotum seen, which is extending along the spermatic cord, which disappears on lying down. Skin over the scrotum is normal. Pen is normal. Hernial emphasis, no cough impulse. Summary of the case: 34-year-old gentleman presented with the swelling in the left side of the scrotum for the past 3 years, starting as swelling in the lower part of the scrotum, which is slowly increasing in size, grown up to the root of the scrotum. Swelling disappears on lying down and reappears on standing and walking, and is associated with dull aching pain for the last 6 months, which is more during the end of the day. No complaints of pain, abdomen, or urinary complaints. Examination: a mass of dilated vein feeling like bag of worms is palpable on the left side of the scrotum, along with left spermatic cord extending from the upper pole of the testis up to the superficial inguinal ring. No impulse on cough is palpable, but thrill is palpable. Swelling disappears on lying down and reappears on standing. Testicular volume on the left side is small compared to the right side, and abdominal examination is normal. So this, my provisional diagnosis would be that this is a case of left-sided primary varicocele.
Okay. If you go back to your history, I have many reservations regarding how you have presented, because varicocele, you presented it like a varicose vein, but typically, though it is like a varicose vein, but very important short case as far as urology is concerned, not for general surgeons, but for urology. Okay, but still you should know. First, you said that the patient was 34 years age, isn't it? So varicocele is common. Is it very common at 34 years?
No, sir. It's towards the
common in adolescent. 11 to 20 years, it's very common. Number two, you may in the family history, what you have missed and which is very important and which goes with varicocele, why varicocele has become so important for urologists is, in the family history, you didn't mention whether the patient has got any children or not.
Oh, yes, sir. Fertility, yes.
Yeah, so that is the most important reason why varicocele is treated, because fertility means what happens in varicocele? Usually the sperm count, it becomes less. So it's
Yes.
a treatable cause, where treatable cause of infertility in males. So that is why it is so important. Okay. So you should mention about that. Number two is you mentioned swelling in the root of the scrotum, isn't it?
Yes, sir.
Lower part of the scrotum. Do you find it is a swelling? Is it like an hernia as you have presented? It increases.
No, sir.
So it does not appear like a swelling as a whole.
Yes, sir.
So there are, you find certain cord-like structures which are present and which, yes, definitely increases on standing and decreases on lying down. But one thing you should also mention that whenever the patient tries to do any weightlifting object, so that increases in size. Though it also occurs in hernia, but there is a difference. So those swellings, those
Yes.
cords, they increase in size. Right.
Yes. Yes.
So these are the things, and these are the things in the history which I feel you should have mentioned. And also, okay, so these are the things you should have mentioned, right? And
He said mass per abdomen. He said mass per abdomen.
Yes.
What mass in the abdomen is more important in a patient who has got a left-sided varicocele?
So, left-sided, sir, renal cell carcinoma, sir.
Yeah. So you should specifically look for any renal lump.
Renal lump, yes.
Okay, patient with renal carcinoma, one of the presentation may be left-sided varicocele. Why?
So because there is invasion of if there is invasion of left renal vein, sir, so that would compress the left
What is the difference in termination of testicular vein on right and left side?
So right testicular vein, sir, drains obliquely directly into the inferior vena cava.
Yeah.
And the left testicular vein, sir, ends perpendicularly drains perpendicularly to the left renal vein, sir.
Yeah.
okay, and in examination also, the other thing which you have missed is you should have examined the patient after doing a Valsava's maneuver, right?
Yes.
So once you do a Valsava's maneuver, the veins they increase in size.
Yes.
Now those
And you said thrill. Actually, there is no thrill. If you examine a patient of varicocele, it's a dilated veins. Over a dilated vein, you don't find thrill. If the patient coughs, you may have some impulse coming to the veins because of same in Valsalva, but it's not thrill. Thrill is because of hypervascularity. You don't find thrill in varicocele.
Okay. So Valsava's maneuver you should mention, right? Okay. Now, what are the causes of, means sir has already discussed, apart from the anatomical abnormality of the draining vein on the left and the right side, what are the other causes of varicocele?
So there the incompetence of testicular valve, testicular vein valve, sir, that could be one of the cause. Then the left renal vein, sir, drains 8 to 10 centimeter above the right renal vein.
No, 10 centimeter is too high. It's not 10 centimeter.
10 centimeters is the thorax. Huh? No, right. One is the anatomical abnormality, left vein drains straight into the left renal vein. The number two is, you know what is nutcracker effect? Nutcracker effect is when the superior mesenteric artery arises from the aorta and the left renal vein passes in between them.
Yes.
So
Yes.
it gets
It's compressed between aorta
and also number of tributaries, like when they increase in number, those also increase the means volume of those veins. Now, what is the effect of this varicocele?
So the varicocele causes there is dysregulation of the local counter thermoregulatory mechanism in the testis, which hampers the spermatogenesis. The thermoregulatory mechanism, the spermatogenesis is hampered as there is the local temperature maintenance is hampered. Plus, there is dysfunction of the Leydig cells at the raised temperature, and so localized due to the increase in the blood flow around the testis, there is a depletion of the glycogen stores, which also hampers that, sir, and there is localized ischemia as well, sir.
Okay. So all means there is first you said because of hyperthermia, the sperm function it gets damaged.
Okay, you said, Mehul said on inspection, you can see there is some swelling in the scrotum.
Yes, sir.
So what is the likely grade of this varicocele? When it is seen on inspection?
It's a grade 3, sir.
Grade 3. So grade 3 is you can see the dilated veins on inspection.
You know the grading system, na?
Yes, sir. Yes, sir. Grade
You are
1,
aware
sir.
of this?
So grade 1 is when on Valsava, sir, we can palpate the veins. Grade 2 is without Valsava, sir, we can palpate the veins, and grade 3 is we can visibly see the veins.
And grade 0 is when you cannot see anything, but you can detect on ultrasound. Right?
Yes.
So 0, 1, 2, 3. Okay, right.
0,
Now,
1, 2, 3.
what are you going to do with this patient? Quickly, we'll wrap it up. Huh?
So I would, yes, so I would like to go for Palamo's procedure,
What do you do?
the ligation of the.
Would you do any investigation directly?
Yes,
You
sir.
go for operation. Would you like to do any?
Oh no, sir. So I would like to. So I would like to do in color Doppler, sir. To
Color
look
Doppler
for
is
the.
not, color Doppler is not an important investigation. It is known as what? Color Doppler will give you vascularity, but it won't show increased vascularity as you think. So it is known as powered Doppler. What is the difference between powered Doppler and colored Doppler?
So power Doppler, sir, would tell us about the reflux of if there is any reflux of
So that is
blood flow, sir.
important. That is the main thing
Yes,
which you want to see. So we want to see the reflux. Okay. And also what else on ultrasound apart from colored Doppler? Do you want to
So
do
the size of
Yes.
the veins, sir.
Not the size of the veins, the size of the testis.
Size of the, yes, sir. Yeah, I also want to see the size of the testis, sir. There is decreasing the volume and size.
You said you would like to do surgery. What are the indications of surgery in a varicocele?
So, for a grade 2 and 3 varicocele, if there are symptoms of infertility or subfertility, or if it causes pain, or if and for cosmetic reasons as well, sir, I would like to go for surgery.
Now, with a patient who has got a grade 0 varicocele with an abnormal sperm count, would you like to do surgery?
Yes, sir.
In a patient, you would like to do surgery. Suppose the patient,
Yes.
the commonest age is 11 to 20 years. So he's adolescent. So do you feel that the sperm count will be normal? Or will the patient be able to have that much of sperm to grade you? Means take you towards surgery? No, no.
No, sir.
So what is important in ultrasound? It is the size.
Size.
What is the size criteria? Do you know the size criteria?
So, if there is a decrease in the testicular volume of the affected side, which is if it is more than 20%
Yes.
of the normal side, decrease in the volume, more than 20% normal side, then I would like to go for.
So if it is more than 20%, then you would like to go in for surgery. The
Yes.
other thing which is not written in your book is, from where you have read, as I can make out, what is the other thing in ultrasound which is very important? Do you know what is peak retrograde flow? So that is important in adolescent. Apart from size, what they see is how much of the blood flow is coming back into the testis. So that is, if it is more than 38 centimeters per second, that is what is written, then you go in for surgery. If it is less than that, you don't do surgery. Okay. So that is an important thing. So for adolescent, sperm count, for adults, you can take sperm count. For adolescent, sperm count is very difficult to gauge. Okay. Okay. Now, what kind of surgery will you do? Now tell me this.
So I would like to go for Palamo's.
What is Palamo's operation?
So here we ligate the testicular veins, sir.
Where?
So in the retroperitoneum.
What is the complication, hazard of doing a Palamo's operation?
So it could injure the. We could also ligate the testicular artery, sir, in case of testicular vein.
So what will happen?
So there, Generally, sir, there is collateral circulation in the testis, but in 20 to 30% of cases, it could lead to testicular atrophy, sir.
Testicular atrophy, it is very difficult, means we do not get it. The main complication is not related to testicular artery. It is very difficult to ligate that because you can see the testicular artery at that point. The testicular artery is quite big. The problem lies with the lymphatics. So if you, instead of tying the veins, the lymphatics goes with the veins. If you tie it at a later date, the patient will develop what? Hydrocele. Okay.
Yes,
How do you know that your surgery is successful in this patient, 34 years?
so there is reduction in the size of the tortuous veins.
34 years, you can do a sperm count. If you find that the sperm count becomes normal,
Yes.
means there are less abnormal sperms, more motile sperms, then you feel that you are successful.
Surgeries.
Right? What are the other ways of doing the operation?
So we can also go for laparoscopic approach, and we can also ligate the veins through the spermatic cord.
Scrotal route. Excision and ligation.
Excision and ligation.
So it is better to say we can do a retroperitoneal ligation, we can do an inguinal ligation, we can do a subinguinal ligation. So these are the three ways, but the lower you come down, the failure rate becomes much more high.
Yes.
As you come down lower. And recently what the urologists are doing is they are also doing radio frequency like the varicose veins we do. You can do that also using an ultrasound. Okay.
Okay.
Okay, sir. Makunda.
Okay, thank you. Thank you. Mehul has to go for a medical team also. Okay. Thank you. Thank you, Dr. Gupte.
Thank you.
Thank you. Yeah, be called. Yeah, जल्दी लग रहा है यार. Medical team.
So, back up.
एक मिनट. Very good.